Okay, well, we're at 12:01 and I want to make sure that Peter has his full time. So I think we'll go ahead and get started. And I just wanted to welcome everybody to our UCLA COVID-19 seminar series. And I'm really delighted to introduce Peter Szilagyi as our speaker today, especially because he's from my home department, Pediatrics. And Peter is Professor of Pediatrics, Executive Vice Chair, and Vice Chair for Clinical Research in Pediatrics at UCLA. He did his medical school training at University of Rochester School of Medicine and Dentistry, and his residency and fellowship in pediatrics at Strong Memorial Hospital at the University of Rochester. For more than 2 decades, he studied strategies to improve immunization rates for child, adolescent, and adult vaccines. And he's had multiple externally funded grants from NIH, CDC, AHRQ, and other sources. And since September 2016, he's served as a voting member of the CDC's Advisory Committee on Immunization Practices, or the ACIP. And he chairs the ACIP's HPV working group, and is a member of the ACIP's Influenza and Child and Adolescent Working Groups. He's also a leader within the Academic Pediatric Association, and since 2009, he's been editor-in-chief of Academic Pediatrics. He's very interested in dissemination and implementation and scaling up of successful interventions in primary care and public health. And since December 2014, he served as one of 18 voting commissioners on the Medicaid and State Children's Health Insurance Program Access and Payment Commission, or MACPAC, which advises Congress and HHS on relevant health insurance policy issues. And with the onset of the COVID-19 pandemic, he's now using all of his amazing expertise in vaccination rates and just on vaccines in general to study the levels of vaccine hesitancy for a future SARS-CoV-2 vaccine in the US. And so this is obviously of critical importance for controlling the pandemic. And so we're really looking forward to his talk, which is titled Public Confidence in COVID-19 Vaccines. So Peter, we're looking forward to your talk. Please go ahead. And if I can just ask everybody, please, to mute themselves and to turn off their cameras so that Peter has the full bandwidth. Thank you.
Great. Thank you very much, Bridget, for a wonderful introduction. And it's a pleasure and an honor to be speaking at this seminar. Let me just, and I will get going. I just want to make sure, can everybody, Bridget, can you hear me and see my slides?
Yes,
okay.
You're perfect.
Great. All right. So I have no disclosures, except that I did borrow some slides or parts of slides from CDC experts with whom I work. And I have no financial conflicts of interest. So what I want to talk about today are 3 topics, 3 related topics. Planning for COVID-19 vaccine distribution. This is obviously super hot right now. The Understanding America study, which is a national and LA County study, and implications for public confidence in COVID-19 vaccines. I do want to spend about 10 minutes talking about planning for the vaccine distribution because it sets the context for the studies with Understanding America study and for a study that we were funded for by a local UCLA grant, and I'll talk about that in a little bit. So planning for vaccine distribution, and I know lots of people are interested in this. Just a very quick update. So as you probably know, and I think most of you know much of this, there's over 200 COVID vaccines currently under development across the world. Within the United States, there's 4 vaccines that are in active phase 3 clinical trials. 6 vaccines have been in phase 1 and 2 trials, and there's more coming down the pike. This is a summary slide showing the most current vaccines. So there are 2 mRNA vaccines, Moderna and Pfizer. Moderna has actually completed enrollment, and within a very short time, we will have interim analyses from their vaccine. It's a 2-dose vaccine. Pfizer vaccine that everybody has been hearing about is also an mRNA vaccine, 2 doses, 21 days apart. Currently, they have interim analysis on 18 to 85-year-olds, but they're already down to starting or about to enroll younger individuals. They have 44,000 participants, aiming for 60,000. And we have interim analysis, and I'll talk more about this. AstraZeneca and Janssen are also in phase 3 trials, as many of you know, and then there's vaccines that are in phase 1 and 2 trials. So this is coming down the pike. Many people across the United States are interested and concerned about who gets enrolled in these vaccine trials. And this is data just from Moderna that was presented to us at ACIP relatively recently. From their vaccine trial, 20% are Hispanic, 10% are Black, 27% are living with comorbidities, and you can see the age distribution. So these trials are trying very hard to enroll representative individuals. I've shown you here a timeline for the vaccine clinical development. So Operation Warp Speed's goal is 300 million doses, with the initial doses available hopefully before January 2021. Vaccine commercial scale manufacture is proceeding at risk. We'll talk more about this, but the clinical efficacy outcome is a vaccine effectiveness of at least 30%. The confidence intervals that we set at ACIP was 30% to 70%, but hopefully over 50%, with a minimum safety follow-up with a median of 2 months after the second dose or the final dose. And you can see this timeline here, which shows phase 1 trials in kind of light green and phase 1 and 2 trials and phase 3 trials in dark green. I'm expecting I'll tell you about an EUA, but I'm expecting an EUA to go to FDA from the Pfizer vaccine very shortly, and then shortly followed by an EUA application by Moderna. So this is really exciting. Everybody knows about this. This was, other than the election, this was the big news coming out on November 9th, and I'm gonna quickly summarize the Pfizer vaccine. The huge news, and what was stunning to many of us, was that it appears an interim analysis to be 90% effective in preventing the infection. The initial interim analysis that was proposed was to wait until there were about 30 to 40 cases. Actually, many of us on ACIP thought that was too few. They redid it. We're waiting for about 50 or 60 cases, and then because of the spike in coronavirus across the United States, they ended up with 94 cases, did an interim analysis. They're gonna continue the trial to at least 164 cases and 5 months, although there was issues about that. They do not have results for hospitalizations or deaths. The results they have is preventing infection. And we haven't seen interim safety data yet, but this is what they will be showing FDA shortly. But I do have to say that there were no serious safety concerns in phase 1 and 2 trials. They're hoping to get out 30 to 40 million doses by the end of 2020. There's likely to be an emergency use authorization to FDA. There are storage and handling issues, feasibility issues. This talk is gonna all be about rollout and feasibility. As you know, the storage is at minus 70 degrees Celsius, and then for several days they could store for not so low of a temperature, and the 2 doses 21 days apart. That was a quick summary of the Pfizer trial. So people have asked me for this talk to describe what's going to happen. What is the approval process? What's going to happen? So I'm going to walk through that. So we're in the clinical development phase. Then it's going to go to FDA, and what they're going to likely do is evaluate an emergency use authorization, or an EUA. There is a wonderful committee of external advisors for VRBPAC, which reviews for FDA and provides input into the safety and efficacy of the vaccine. Then it will come quickly to ACIP for review of safety and efficacy of the vaccine. And I can tell you that we have an emergency meeting scheduled for November 23rd at ACIP. It then goes to CDC for their recommendation and post-approval monitoring. And I'm not going to talk about this today, but there's an amazing safety monitoring process that CDC is rolling out. CDC will then allocate the vaccine to states. States have developed, many states or groups of states have developed committees to review the safety and efficacy of the vaccine and recommend allocation. California has what's called the California Scientific Safety Review Group. I am honored to be part of this review group, and we've now banded with Washington, Oregon, and Nevada, so it's actually the Western States Review Group, to review the scientific safety of the vaccine and recommend for the state of California about the safety of the vaccine. There's another equally important review group that's going to be looking at the allocation of the vaccine. And then the states will allocate the vaccine. So what is an EUA? An EUA has to do with a different level of evidence for the favorable benefit and risk than typical vaccines. It's basically that the benefit and risk of the known benefits and risks are significantly or outweigh, the known benefits outweigh the risks. They take into account the rapid and widespread deployment to millions of individuals, in this case, the pandemic. They take into account that it's going to be given to healthy people, and the VE, the vaccine effectiveness, should be greater than 50% versus placebo, with confidence intervals of 30 to 90%, ACIP's 30 to 70%. The clinical endpoint is infection, not necessarily hospitalization or disease. And the median duration of follow-up is 2 months for at least 50% of participants. So that will lead to an emergency use authorization. And after the FDA gives an EUA, it will come to ACIP. And we will have 2 questions to review. Should the vaccine be recommended, and to whom should it be recommended? And I'm going to walk through this briefly. So should the COVID-19 vaccine be recommended? People may not know this, but several years ago, ACIP adopted a very rigorous process to make decisions on vaccine recommendations. This is a worldwide process called the Evidence to Recommendation Framework. It's being used not only for vaccines, but for other interventions. And so we at ACIP review, what is the public health problem? What are the benefits? What are the harms? What are the values of the target for the target population? Do they value this intervention? Is this intervention acceptable, feasible? What are the resource use considerations? And that, that includes cost effectiveness, which won't be reviewed by us for COVID vaccines, and issues of equity. Today, most of my talk is going to focus on values and acceptability, which is really important for ACIP, which will then allocate to the states, and then the states will allocate it to localities. The second question we're dealing with is, to whom should allocation of the vaccines be recommended? And I have to say, for 6 months at ACIP, we've been addressing this and looking at the evidence. And I'm going to summarize some of this for you right here. So as you probably know, there are 4 main subgroups that we and multiple other groups have been addressing. This includes the National Academy of Medicine, Hopkins Ethics, World Health Organization, numerous groups. So this includes in the dark circle, healthcare personnel. There's 20 million of us. Essential workers, which overlaps healthcare personnel. There's actually, now this slide is already old, there's 87 million essential workers. Individuals with high-risk medical conditions, there's 100 million, and adults over 65 years old, there's 53 million. These are overlapping groups, and obviously there's significant heterogeneity within these groups. And we've been trying to address which groups to allocate. And ACIP has adopted an ethical principles. Multiple other groups have recommended ethical principles for how the vaccine should be allocated. We're using the following criteria. How can we maximize the benefits, promote justice, mitigate health inequities, and be transparent? And if you want to learn more about these, there's a couple articles from ACIP and JAMA recently, and then Beth Bell is going to have an article just, I think, this week or next week coming out, ACIP in JAMA. So I'm not going to go through this for all the groups, but just for healthcare personnel, for example, we think healthcare personnel is a good group to recommend for the initial allocation because it preserves the capacity of healthcare. It has a multiplier effect. It does promote justice because individuals who are healthcare personnel and have contact with the public are at higher risk. And it does mitigate health inequities because healthcare personnel are racial, ethnic, and minority groups are disproportionately represented in low-wage healthcare personnel. So here's a distribution plan, and this will likely shift a little bit, but it's similar. The first group, when very limited doses are available, will be healthcare personnel. And then we are debating right now who should be phase 1B. And this is when there's still very limited supply. So this would be older adults, potentially long-term facilities, maybe phase 2 or within phase 1B, and states will have some flexibility in this, will be who will be the essential healthcare workers, congregate settings, and other individuals. And then the third group will be when there's continued vaccination and a large supply. Now, the CDC has done some serious modeling analyses for what would happen if we allocate in phase 1B to the different groups, those different circles that I showed you. And interestingly, initially vaccinating in phase 1B, not 1A, phase 1B, the ultimate impact on the pandemic is relatively similar, whether we allocate it to adults over 65 or essential workers or high-risk adults. There's some differences. So if we allocate the vaccine to adults over 65, it averts the most deaths by a little bit. If we allocate to essential workers or high-risk adults, that averts the most infections. The most important issue here is early vaccine rollout. We are spiking, as you all know, with the epidemic, and the earlier we roll this vaccine out, no matter what is going to be eventually recommended for phase 1B, the faster we will be to squelch this epidemic. Logistics, I've mentioned this, there's storage and handling issues. That Pfizer vaccine has to be stored at -70. Moderna and some of the other vaccines at around -20, there's variation. CDC is working on a very good supply chain plan that involves pharmacies, hospitals, doctor's office, public health settings. But ultimately, vaccine allocation will be up to local and state agencies. Oh, and by the way, University of California has an ethics work group that has been working on potential distribution of the vaccine. Now, the impact of the vaccine all depends on vaccines that are at least moderately effective, a vaccine that is safe, equitable and efficient distribution, and populations who accept the vaccination. I have heard the statement that vaccines don't save lives, vaccination saves lives. If you can't get it into the public, then it won't help. So some key questions: will the general public accept the vaccines? Will high-risk groups accept the vaccines? And you can see the high-risk groups: minority groups, essential workers, those at high-risk conditions, over 65. Can effective messaging affect people's confidence in the vaccines? What are the preferences for the sites for vaccinations, and what are other logistics? So several months ago, I submitted a grant to UCLA and was awarded a grant for the following specific aims: to assess the prevalence of vaccine hesitancy for the SARS-CoV vaccine in LA County, to assess preferences for logistics for the public, and look at vulnerable subgroups. And by logistics, I mean sites for vaccination, tracking systems, and messaging and educational campaigns. And to look at vaccine hesitancy for influenza vaccine in light of COVID vaccine. We're only in month 3 of the grant, so we really just started. And I'm going to focus today on prevalence of vaccine hesitancy. So this internal grant led me to work with a number of really wonderful individuals, and all the credit for this project goes to these other people. Natalie Vizueta, who's the program manager. Craig Fox will be coming into our project very shortly. He's a behavioral economist. Ram Vangala for Inspire Statistics, so these are the UCLA team. At USC, there's 2 wonderful individuals, Kyla Thomas and Ari Kepton, who have been running incredible surveys that I'm about to tell you about. And the LA Department of Health, Megha Shah and Yan Chui. And so our partnership is these 3 groups. And the UCLA grant has enabled larger collaborations. And so I'm going to tell you about 2 major online surveys to assess the public's opinion about the vaccines. A national survey, the Understanding America survey, and a subset of it essentially, which is the LA Barometer survey. So let me tell you about the Understanding America study. This is a national internet panel of households. There are 9,000 individuals in this panel over 18 of age. The recruitment has been done incredibly carefully. It's a probability-based sample that's representative in the United States. You've heard a lot about other surveys. I have to say many of the surveys use convenience samples. This is anything but a convenience sample. Individuals are recruited using address-based sampling. It's actually almost the same methods as in one of the other really large surveys, which is run by Ipsos, and I've actually worked closely with Ipsos in a knowledge panel. There's a weighted recruitment rate. Panelists receive a tablet and internet if needed. The surveys, so there are 9,000 individuals, and what's really neat about this survey is that 8,200 almost individuals have agreed to 2 surveys per month. So since April or even earlier, they've been surveyed about all sorts of questions about coronavirus. And it's been twice a month. So we can now assess trends in people's attitudes toward coronavirus and the vaccine, now the vaccines. Surveys are answered online, $20 per 30 minutes of survey time. And really importantly, because of the rigorous methodology, they use sampling weights plus post-stratification weights to correct for differential non-response by sex, race and ethnicity, age, education, and geography, which makes the survey, as far as we can tell, relatively representative of the United States. Now there's a subpanel of the Understanding America panel, and that's 1,800 individuals in Los Angeles County. 1,200 of these individuals have agreed to take surveys every 2 weeks, and they've been surveyed actually since the beginning of the year using survey weights that are similar process as the National Understanding America survey. And I'm showing you here some demographics of the LA Barometer panel, which is the 1,800 versus LA County. You can see there's maybe a little bit more females. The age distribution is very similar. And what's really important, I think, for this talk, the race and ethnicity distribution is very similar to LA County. So both the national and the LA surveys have been asking questions about coronavirus since April. They ask questions about knowledge and expectations, symptoms, testing and medical care, protective, social and health behaviors, risk perceptions, your risk of the disease, and multiple different behaviors, among others. And I'm going to hone in on one question because this is just one talk, which they've been asking since April. And are you likely to get a coronavirus vaccine if it is available? Nationally. So this slide shows the percent of individuals who say they are likely to get a coronavirus vaccine if it is available. You could see that it starts in April, where there was an 82% who said they are likely to get a vaccine. The confidence intervals are shown in shaded area. There were 2 periods where there were very few, the sample size just was low, so it's wide confidence intervals, and I wouldn't pay attention to that. Some bad news, as you have heard, is that the percentage of individuals who say they're likely to get a vaccine has really gone down markedly. So this is for the entire population. And I'm going to show you data stratified by demographics. So by gender, and I'm showing you just in the boxes, just the latest data, and the latest data is November. So this is as late as recent as you can get. Women are about 10% less likely to say they will get a vaccine than men. By age, I view this as, in a way, good news, and in a way, bad news. The good news is that individuals over 65 years of age are more likely to say they will get a vaccine. Individuals under 40 are less likely. Now, they're less risk from the disease, but they're also less likely to get a vaccine. And increasingly, evidence is showing that a lot of the infection is being spread by younger individuals. There is a marked disparity by education level. So individuals who finish college, who have a bachelor's degree, 3/4 are likely to get a vaccine versus all others, about half. By race and ethnicity, this is very disturbing to me. And all of these trends have continued. So if you look at the bottom, individuals who are Black, only about 50% say they're likely to get a vaccine. Similarly, Hispanic, significantly more individuals who are white, and other, which is a large part is Asian, are more likely to get a vaccine. And you can see if you follow the trend that this has been continuing over months. This shows the adjusted odds of being likely to get a vaccine early in October by age group. So here we are adjusting for gender, race and ethnicity, and education. And as you can see, individuals who are over 65 years of age have about twice the odds of saying they will get a vaccine than individuals who are younger, even after adjustments. And by race and ethnicity, individuals who are Black have about 1/2 the odds of getting a vaccine. Individuals who are Asians have about twice the odds of saying they will get a vaccine. Now, this slide shows trends. So basically what this slide does is it compares April to early October. Not quite December, but early October. And one of the disturbing points on this slide is whether you look by age group or whether you look by race and ethnicity, there's been about a 20% decline in interest in getting the vaccine, adjusted for the other characteristics. So to me, this is pretty disturbing. So let's hone in on LA County. We actually asked a slightly different question in LA County, honing in more on hesitancy. So here's what we asked, and it's really on the x-axis, is do you plan to get vaccinated or not? And the answers were yes, as soon as the vaccine's available. Yes, but I will wait and see. No, but I'll wait and see. No, or unsure. So I think this hones in a little bit more on this whole issue of vaccine hesitancy. And as you can see, 24% said yes right away. 39% said yes, but I'd rather have other people, I want to wait and see. And then you can see the percentage no and unsure. And these are the confidence intervals. And I'm showing you the data now in a little bit different way. This is shown in a stacked histogram. So in a sense, what I've done here is shown the data. Yes is green, no is red, different couple shades of red, and unsure is orange. And I'm kind of looking at this as hesitant is orange for sure, and maybe orange plus red. So, you know, the good news is that about 60% of LA County residents, I think, are likely to get a vaccine. Bad news is 20% are saying no, and there's a fair number who are unsure. And I'm going to go through the same kind of analyses by gender. You could see women are far less likely to say yes than men. By age group, I think this is a little bit encouraging. Similar trends to the national trends, right? So about 70% feel that they would get a vaccine among over 65-year-olds, but a lot lower for younger. By a college education, this is pretty impressive. 80% of LA County residents say that they would get a vaccine, although a large percentage want to wait and see. And by race and ethnicity, for the LA County data, we were separated out Asian. So you can see white, Latino, Black, Asian, and mixed race. And obviously the disturbing data here is that among Black individuals in LA County, just like national, the percentage of individuals who say that they would get the vaccine is significantly lower. And a lot of people are waiting and seeing. Now in LA County, and we'll do this nationally, but this data is just hot off the press, so we haven't done this yet nationally. We the surveys ask questions about, are you able to work at home, and then exactly what kind of job you have. So we have figured out who's an essential worker. And this data, and I have not seen this kind of data before, this data shows the percentage of LA County residents who are essential workers or not essential workers who say yes, they would get a vaccine versus no. And it's interesting that there's essentially no difference here. So essential workers are just as likely to say that they will get a vaccine, or you could flip that around. I haven't seen this data before either, but basically what we did is we took the list of chronic diseases that place patients at risk for COVID. So things like diabetes, heart, lung disease, COPD. We used the CDC list, asked patients or asked the respondents who has those conditions, and then separated into chronic disease or no chronic disease. And individuals with chronic disease are a little bit more likely to get the vaccine than individuals without chronic disease. But it's certainly not sky high, even with these high-risk individuals who have chronic disease. And so here I'm trying to give you some summary data for LA County, and I've collapsed into yes, no, and unsure. And here's my interpretation of the data for Los Angeles County. As I've kind of mentioned, women are less likely to get the vaccine. Younger adults will be less likely to get the vaccine. Those without college education or without college degrees, less likely. African Americans, significantly less likely. And there's really no difference in essential workers or chronic disease. So some more questions. We're trying to get under the hood about vaccine hesitancy. So we asked, are you more concerned about COVID illness, the disease, or about the vaccine side effects? And as you can see here, 30% are more concerned about the disease than the risk from vaccine. About 15% more concerned about the risks from the vaccine, 40% both, and then you can see neither. I think this is a really interesting slide. And I think this gets at the heart of vaccine hesitancy. We asked, how much do you trust the government approval process to ensure COVID-19 vaccine is safe for the public? Are you kind of seeing why I went through the approval process at the beginning of this talk? So here's what we found, and I've broken the data into the same demographic groups that you just saw before. But this isn't asking, will you get the vaccine? It's asking, how much do you trust the government approval process? And essentially, the data look the same as will you get the vaccine? So women, younger age groups, those without a college degree, Black Americans, but also Latino, have significantly less trust in the vaccine. So in the government approval process. So if you look at the red, which is do not trust, or even the orange, which is somewhat trust, you can see that there's significant amount of mistrust of the approval process. And I haven't done it, but if I overlaid this with the other graph, they would be very, very, very similar, which tells me that trust underlies vaccine hesitancy for this particular vaccine. So future work in the next few, I said the next 3 months, but it's actually the next few weeks, as well as the next 3 months. We're going to look at the likelihood of getting a vaccine for key allocation groups much more in detail. We're going to be doing multivariate analysis, adjusting not only for demographics, but for social distancing and their other behaviors. In other words, are the people who are not going to get the vaccine also the people who are not masking or social distancing? We're going to analyze, we've actually added questions, very detailed questions about vaccine hesitancy. So you probably don't know it, but the World Health Organization has come up with a survey instrument called the Vaccine Hesitancy Scale. My group has actually modified that scale for influenza vaccine and HPV vaccine, and we're going to modify it for COVID vaccine and get more, I think, more confidence in the instrument itself. And then we're going to be looking more at reasons underlying vaccine confidence. We'll also ask about logistics, like sources of information or sites. And I'll talk more about it in a minute, but we'll be testing messages based on behavioral economic principles or other principles. And we'll ask about flu vaccine in the context of COVID vaccine. Now, why is this important? I think there are a number of benefits of knowing the likelihood of getting the vaccine, even though this is hypothetical in a way. I think this data will be important to inform key groups. So I remember I talked earlier in this talk about how it will provide ACIP and other groups information about the target population. Does the target population value the vaccine? I don't know whether it will actually make a difference in allocation of groups, but I think it is important to know who values the vaccine. And it certainly will feed information into individuals, groups, organizations that are developing messaging, public health campaigns to educate the public. And I'll talk more about this in a minute. I think from a scientific point of view, it provides a better understanding of vaccine confidence and hesitancy, the role of trust, and the need for culturally tailored strategies. If you think about the market disparities by race and ethnicity in the interest in getting a vaccine. So implications for public confidence. This is a conceptual framework that I've been using. World Health Organization adopted this within the past year, actually. And it's not about COVID, but it's about vaccine confidence and factors that affect vaccination. And many of our groups have fed the evidence that led to this World Health Organization model. So what it is basically talks about factors that affect yes or no, are you going to get a vaccine? So a large part is what people think and feel. And you can see the components here, like your perceived risk or worry, confidence, trust, safety concerns. Social processes. So provider recommendation is really important. Social or gender norms, rumors. Those two lead toward motivation, your readiness, your willingness, your intention, your hesitancy. But then we should not forget there are many practical issues that end up getting in the way of getting a vaccine or facilitating getting a vaccine, such as the availability, the convenience, the costs, and a number of other factors, many of which we have studied. These all combine, motivation and practical issues kind of combine to getting vaccinated or not. And as you're looking at this, think about COVID vaccine, and you'll see how I think these are very relevant to whether or not the public is going to get COVID vaccine and whether or not subgroups of the public will get the COVID vaccine. So I don't want to do a talk on vaccine hesitancy in general, but just to give you some data from across the United States about vaccine hesitancy. Our group and others have been studying the prevalence of hesitancy. So let me just give you a kind of a 30,000 foot snapshot of hesitancy. What this table shows is different kinds of vaccines. So routine vaccines for children, child influenza vaccine, adolescent HPV vaccine, and adult vaccines. You can see in this column the vaccination rates. So for routine vaccinations, they're really high for children, as you probably know, 90 to 95%. But for influenza vaccine, the vaccination rates are only 64% for children. For adolescent HPV vaccine, the vaccination rate across the country is 51% for completion and maybe 70% for getting at least one vaccine. And you can see the vaccination rates for adult vaccines, which are dismally low. So my group has, together with a large group actually, have done two large national surveys, online surveys, not using this exact mechanism, but using a very parallel mechanism, the Ipsos survey, to measure the percent of US residents who are hesitant. So in this case, parents of children and parents of adolescents. And you can see vaccine hesitancy for routine vaccines is high at 6%. But vaccine hesitancy using the World Health Organization scale, or our modified version of the scale, is 26% for influenza and 23% for HPV vaccine. So that means a fair amount of hesitancy that's entrenched for influenza vaccine and HPV vaccine. But it doesn't account for the low vaccination rates, which tells me that it's kind of a combination of vaccine hesitancy and practical or other issues. The themes underlying hesitancy, the reasons for hesitancy, or the reasons for getting a vaccine are the following, and this is from our national surveys, and this is for these vaccines. Is the vaccine beneficial for me? It turns out people think more about whether it's beneficial for them than is it beneficial for society or for others. And that's really relevant for COVID vaccines, right? Vaccine, does it work? Is it safe? and issues of trust is becoming more and more important, even in general vaccines. The World Health Organization has issued the top 10 threats to global health. And interestingly, global influenza pandemic was the third, and vaccine hesitancy is one of the top 10 threats to global health. And again, this is not a talk about vaccine hesitancy, but I want to point out that there is a continuum of vaccine acceptance. Vaccine hesitancy is not an all or none concept. So there's people, you hear about the sort of the anti-vaccinators over on this side, and people who refuse vaccines are not necessarily anti-vaccinators. They refuse. These are good people. These are good parents. They care about themselves, their family members, their children. They just refuse vaccines. Then there's many people who are refusers, but are kind of unsure. They may be kind of that wait and see, right? No, I don't want to get a COVID vaccine, wait and see. People who delay, people who accept but are unsure. That's also maybe the people who said yes, but wait and see for COVID vaccine, and then the individuals who accept. It's a continuum. And I want to point out that studies have shown that we can address vaccine hesitancy. So just as vaccine hesitancy is not a dichotomous thing, like either you're hesitant or you're not, vaccine hesitancy does not doom that you're never going to get a vaccine. So this is not a talk about vaccine hesitancy, but I did want to show that for HPV vaccine, and do you remember that I just showed you that HPV vaccination rates are very low, and that hesitancy accounts for a large part of it, maybe half of the reason or a little bit more. These are studies that have shown that interventions specifically intervening on vaccine hesitancy may improve hesitancy. So Brewer and Gilkey from North Carolina, Amanda Dempsey from Colorado, Cindy Rand, our group from Rochester and UCLA, our group from UCLA and CHOP, and actually across the country, have done randomized trials or other interventions that have studied communication training. If you train providers on vaccine communication, you can have an impact on vaccination rates or reducing missed opportunities for vaccinations. And in the vaccine world, if you can scale up an intervention very widely, then you can potentially impact the public in a very significant way, even with small percentage points. And you can see in my world, this is actually pretty big impact on vaccination rates or missed opportunities for HPV vaccine, for which there's a lot of hesitancy. So this gives me a fair amount of optimism that we might be able to impact the hesitancy for COVID vaccine. So practice level interventions can work, and training messaging for clinicians may help. So what are the strategies that are needed to address COVID vaccine hesitancy? I think the strategies vary, and they should be across many settings. And I'm going to quote Don Berwick, who used to run HHS, who for other things, for quality of care, has said, do everything. And in the face of a pandemic, I think this is one of those situations where we need to do a lot of things to address vaccine hesitancy for COVID vaccine. And the settings involve practices. We can actually train practices and providers or provide phrases for them, health systems, community-based settings. I think we can influence state educational public service announcements or federal educational public service announcements. There are many different modalities that we can use to influence vaccine hesitancy. The modalities can be anything from outreach by reminder recall, phone, letter, text messages, patient portals, or by people, individual outreach, which I call community outreach. We can use traditional media and we can use social media. Now, some of this is tempered by the fact that any one intervention is going to have limited impact. And I'm going to show you an example, two examples from my own studies. So this is not influenza vaccine. And traditional reminders and education. A decade or two ago, we and many others have demonstrated that just reminding individuals about needed vaccines can really help them get vaccines. Well, we've had two sets of large studies that show that it's harder nowadays with influenza vaccine because there's a lot of hesitancy for influenza vaccine. So this one study, these are both published in 2020, this one study, the effect of patient portal reminders, was run at UCLA, throughout UCLA, where we randomized more than 100,000 individuals in UCLA Health to receiving portal reminders about flu vaccine and getting 1, 2, or 3 reminders. Another study looking at effect of state immunization registry reminder recall and testing autodialer text messages or mailed messages across New York State and across the state of Colorado. These are 2 large randomized trials. The one at UCLA had almost no impact on raising influenza vaccination rates. The one in New York and Colorado had a modest impact with autodialers. So not as big of an impact as the more intensive interventions about training communication. The barriers for the traditional methods of reminders and education, the big barrier to this was hesitancy. So getting back to the World Health Organization model, I think there's some factors that are unique or maybe similar in COVID vaccine from these other vaccines. The factors that are unique to COVID vaccine is that there's an immediate impact of the pandemic. If you think about HPV vaccine, we're trying to prevent cancers that are going to happen 20 or 30 years from now. So individuals, the public doesn't see the cancers in their adolescence. Whereas with COVID vaccine, the pandemic is here now affecting all of us. On the other hand, there's the speed of vaccine development and the novelty of the vaccines, which is really on the minds of many individuals. There is a short duration to assess safety with Operation Warp Speed and the very rapid process that I talked about earlier in this talk about how this evaluation process will work. And we won't have data on subpopulations. When traditional vaccines come to ACIP, one of the questions that I always ask and that numerous others always ask is, what is the data on subpopulations? What is the data by age group, by race and ethnicity, by other subpopulations? And we won't have that when the COVID vaccines are rolled out. And then with COVID vaccines, there's this novel new issue of politics and trust in government, which I just showed you. So I think there's kind of 2 big boxes, which is the importance of the roles of public health messaging, communication by providers, and the importance of practical issues like reducing barriers and making vaccination convenient. So we're going to be looking at sites for vaccination. So in LA County, there may be multiple sites for vaccination. We'll look at, we'll ask people what they think of the testing sites, large venues, mobile vans. We'll look at costs and willingness and ability to pay. I know that Operation Warp Speed has been described as there won't be any cost for patients. It's not 100% clear at this time, as of today, what will happen. We'll look at barriers and facilitators, time off from work, waiting times. What would be the impact if vaccines are required for certain work, certain jobs, college, social events, and the importance of reminders. And then we will ask the public about prioritization of vaccines. So one of the interesting things that we're going to get into is using behavioral economic principles. So I just talked about how I think the COVID vaccine hesitancy is a little bit different than the more entrenched hesitancy for other vaccines, for which we have some answers, but they're more intensive interventions. And one of the strategies that we're going to look at is what would be the benefit of using and designing messages that use behavioral economic principles. And so let me just give you a couple examples. Gains versus losses. What would be the benefit if we present the vaccine as this is the positive consequence of the vaccine versus what happens if you don't get the vaccine? This is very nuanced and very minor, but messaging might make a difference for this vaccine. When it's a new vaccine, hesitancy seems to be shifting very quickly and might be modifiable or more modifiable than for the others, than the other vaccines. Scarcity. There's a good evidence in the behavioral economic literature that if something is scarce, people will want it. So should we emphasize the scarcity for the public? What about authority? There's evidence actually in both directions. Does it help whether we say that UCLA doctors or USC doctors or national doctor groups recommend it? I think it would help. And I can talk, and one of the reasons for the safety commissions and those work groups in California and all the other states is that many of us think that even though their process of evaluating the vaccines won't be any different than ACIP, won't be necessarily more rigorous than ACIP or FDA, but the public might listen to the more local, more state groups that are evaluating the safety and efficacy of the vaccines. And I'm not going to go through the others, but we're going to specifically test these. And how are we going to test it? We're going to use this online panel and randomize individuals into getting different kind of messages and asking them, given this message, what's your likelihood of getting a COVID vaccine or not? Using essentially a randomized trial of these online patient panel members. So the CDC is rolling out a 3-pronged strategy about vaccinate with confidence for COVID vaccine. The first is reinforcing trust. And and I think you can see the relevance with respect to the data that I just showed you today. The second is empowering healthcare providers. And what our group is going to add to this is not just empowering healthcare providers, but providing specific phrases and messages and communication strategies for healthcare providers. And another is engaging communities and individuals. And I personally think this is super important in the face of COVID vaccines, particularly for minority groups, individuals with lower levels of education, and certain subgroups of the population for which their trust in community outreach is higher than their trust in state or federal governmental agencies. So in summary, I tried to present to you a careful federal process to evaluate the efficacy and the safety of COVID-19 vaccines, as well as the prioritization. Nationally, the likelihood of getting a vaccine declined, unfortunately, from April to October from 82% to about 62%. Across LA County, 63% of LA County residents plan to get a vaccine, but 11% do not and 17% are unsure. Individuals are less likely to get a vaccine if they are female, young adults, if they don't have a college degree, and if they are Black or of mixed race ethnicity. High-risk groups, many high-risk groups, are very likely to get a vaccine. You remember the data for over 65-year-olds, also the data for essential workers and those with chronic conditions. The proportion of unsure is high, and I think this group is particularly malleable to recommendations by healthcare providers or other providers. It's 17% in LA County, and it's also high for all age groups. So I'm optimistic that this may mean that we may be able to get the vaccination rates higher than what our study suggests. Oh, and trust in the process of evaluating the vaccine is obviously a critical issue and underlying the issue of vaccine hesitancy for COVID vaccine. There is evidence that I presented just a very little evidence that vaccine hesitancy can be attenuated, and we have much work to do in this area. It is not the case that just rolling out a vaccine will get a super high percentage of the population vaccinated. Now, I wish I could show you data, modeling data about what percentage of the population needs to get vaccinated to really stamp out the pandemic. And what's unclear, and it's certainly unclear if different subgroups of the population are going to get vaccinated, because their risk of spreading the disease, the infection to others, varies by the subgroup. So if you think about essential workers versus not essential workers. But we have a lot to do. Just having a vaccine does not mean that people are going to be vaccinated. So we do have a lot to do, and I very much appreciate the funding. The funding for me for this project came from the UCLA David Geffen School of Medicine and the Broad Center, the COVID grant, as well as significant funding from the CTSA program, which has funded and supported a tremendous number of COVID-related projects just over the last few months. Funding for the Understanding America study has come from USC itself, the Gates Foundation, the National Institute on Aging, and the National Science Foundation. And I want to give a big shout out, thank you, to the collaborators of this project, to the brains behind the Understanding America study, Ari Kepton, Kyla Thomas, and a very large group at UCLA, to the brains behind LA County Department of Health, Mega and Yan, and a very, very large group. And we will be feeding information from LA County directly to LA County Department of Health regarding logistics, messaging, and the rollout of the vaccine. And the group at UCLA, who I've worked with for numerous other projects, but I think this is an exciting project to work on. So thanks for listening. Sorry about the tick in my throat for early part of the talk, but I'm happy to answer questions, and I'm hoping there's a lot of interest in how to raise confidence and acceptance of the COVID vaccines. So thank you.
Thank you so much, Peter, for a really fantastic talk, and yeah, lots of food for thought. And I think we have lots of really good questions. I think maybe we'll start with the chat, because we've had questions coming through your whole presentation. There was a question early on from Janet Winikoff about the effectiveness on the vaccine. How is infection determined, PCR versus antibodies? Do we know if the initial randomization produced placebo and treated groups that had the same level of likely exposure, number needed to treat? From her calculation, which is maybe not correct, NNT is 1 in 250. Is that good enough? Any data on how long protection lasts?
Wow, those are all amazing.
There, I know. But even if you just answered some of it, maybe, because we have a lot of questions to get through. Amazing
question. They were using PCR or other similar studies for the infection. The trials were randomized to find the outcome was infection. Subgroup analyses will be hospitalizations and death. They're clearly not powered individually for many of the subgroup analyses. One of the things that has been done, there's been a lot of things done very, very well with the development of the vaccines. So the processes and the outcome measures have been standardized across the different vaccines, across the different trials. So that will give us more confidence in actually comparing the vaccine. And more, because it may be that one vaccine is more effective for younger individuals and maybe perhaps less effective for older individuals. Just as an example, and this is not what you were asking, but the vaccine is actually quite reactogenic. So it's a little bit like Shingrix vaccine. There's a high percentage of individuals that get muscle aches and pains, fever. Many of the vaccines are actually less reactogenic for those over 65. I don't know whether that's good news or bad news. We don't have the efficacy data for those over 65. So does that mean that it will be less effective for those over 65? I don't actually know. But some of these issues are really important. In terms of your question about the people who are enrolled in their trial, I've worried about that well, it's a randomized trial. So presumably the prior, they got placebo. So are they totally unblinded if it's a reactogenic vaccine? It's a good question. The other question is, what is their behavior in terms of social distancing? And is the behavior for the control group, the placebo group, different than the behaviors for the randomized group? I actually do not know whether the companies are actually measuring behavior. I actually hope they do. Okay, the other big ethical issue that you didn't ask about that's going to come up is with very effective vaccines. We never expected a vaccine to be 90% effective. And by the way, your number needed to treat may not be way off. But the ethical question is going to be, what happens to the control group? If there is a very effective vaccine, it will be likely unethical not to offer the vaccine to the control group, to the placebo group. And that breaks the randomized trial. They have thought about that. There's a lot of work going on in terms of what to do. They will still follow individuals for 12 months or potentially beyond, but you can see what happens when you start giving vaccine to the control group. Not everybody in the control group will get the vaccine. There may be differential social behaviors in those individuals in the control group who do and do not get the vaccine. So these are going to be really, really difficult to assess, much less to assess really the differences in the effectiveness across the vaccine, much less the safety profile. So far, the safety profiles have been promising, but it is a very reactogenic vaccine. And for those of us who live in the implementation world, I am nervous about getting people back for the second vaccine if the first vaccine was reactogenic and they got significant local mild reactions from it.
Okay, great. Next question.
That was a long answer to actually a complicated question.
No, that's great. Next question is from Savannah Carson. How much have any of these surveys or results, particularly on vaccine acceptance or trust questions, changed after the election, if at all, and any changes by group?
Yeah, that's a really great question. We are in the field every 2 weeks with this with these surveys, both nationally and locally. So we will find out. There are, and actually the Understanding America study, I did not present this because I kind of want to keep political issues away from it, but the Understanding America study has looked at the relationship between political affiliation and other social distancing with likelihood of getting a vaccine. There has been a relationship. Other studies have looked at that as well. In all honesty, I have a little less faith in the convenience samples, the national samples that are convenience samples, but we are looking very carefully at what happens right after the election. I'm hoping that there will be a potentially a spike in confidence in getting a vaccine, but we don't know that, but we will know that within several weeks because the sample sizes are large enough both for the local and for the national group. So if I had given this talk in 2 weeks, I could have let you know more.
Okay, sounds great. Okay, another one from Saswati Ramaswamy. If I understand what you're saying, only 94 people have gone through phase 3 analysis, and this is what they're using to distribute the vaccine. 44,000 are enrolled, but most of them have not entered phase 3.
That's wrong. So 44,000 have completed 2 months after their second dose. Do you follow that? 94 cases of COVID have arisen out of those 44,000.
Okay, so there's been
94 what I'm saying?
cases.
So 44,000 people have been enrolled and are at least 2 months after the second dose of either the vaccine or a placebo.
Okay, sounds great.
So they have hit their interim analysis point. Out of those 44,000, there have been only 94 cases. It's rising rapidly. And I think we're going to get into the hundreds, but potentially. But I think you were talking about the number of cases, not the number who've actually gone through at least 2 months post the second dose of the vaccine.
Got it. Okay. From Steve Peckman, is there a way to parse out how much the lack of trust in the government approval process is historical or more recent, i.e. resulting from the current administration's anti-science approach to the pandemic?
I wish. The Understanding America study is new. There are, this is a novel platform because it's following the same individuals over time. It's randomly sampling from the same group of individuals over time. And so for example, there are other surveys who are doing cross-sectional surveys, but the questions about trust were not, in the past, the questions about trust with vaccines have not been as detailed about the government evaluation or regulatory system as the questions that we are asking right now. So I do not know whether this is long-standing, whether there has been a bump during the current administration. I can predict, I suspect that there has been a significant increase in hesitancy and potentially even refusal of vaccine because of the issue of trust with the current administration, but I don't have the data to show that. The best data will come, I think, in a way from the natural experiment that's going to happen with a new experiment, but with a new administration. But there's other things that are going to happen at the same time. So more and more, additional vaccines are going to roll out. We'll have more data on vaccine efficacy. We'll have more data potentially on vaccine efficacy for subgroups. So it's not a real experiment. So I can't give you data the way I would like about trust in the government. And even trust in the government in general has not been parsed out as carefully like trust in state or federal. I can tell you that for the LA Barometer survey, we are asking about trust. I can't remember how many different sources of information, but it's not just government. We're asking about trust in organizations, your doctor, news information, CNN, I think. We're asking, I believe, about Fox News, all sorts of trust in a number of different agencies or organizations or sources of information, not just the government. So we will have that information. We're just getting into the game of analyzing this data. And that's why I didn't show very many multivariate analyses, because we're literally just analyzing this right now. But we'll have a lot more data within a month.
From Kelsey Thomas, are there ongoing trials that have a larger proportion of Black or Latinx participants? I'm wondering if safety data from such a trial can be used to discuss patient concerns.
Yeah, there are, I believe one of the trials might be aiming for 100,000 worldwide, but then you get into the issue of, enrollees, enrollees in the trial from other countries, and will the American public trust vaccine data that are from other countries? This is about as big from America, I think, as we're going to get, although I'm not positive about that. Because the endpoints and the processes are very similar across the different vaccine trials, that gives me greater confidence in evaluating across the trials. I don't think that the percentage that are minority are going to vary very much or be much higher than what I showed you for Moderna. I believe the percentage that are minority and from the Pfizer vaccine is somewhat similar to the percentage that are in the Moderna vaccine. Now, let me tell you one other thing. I have been talking personally with the experts at CDC for flu vaccine, HPV vaccine, and childhood vaccines. And I asked them the question, actually, I asked them this question before COVID. Is there evidence that that vaccine effectiveness in these type of clinical trials should vary by minority status? So is there evidence that there are genetic reasons why a vaccine might be more effective for one race or ethnicity versus the other? And they were not able to show me any evidence for flu vaccine, HPV vaccine, or childhood vaccines. This is prior to COVID. COVID is complicated because, for example, Black populations are far more likely to be essential workers, to be lower income, to have more crowded conditions. So it's not all about genetics, it's also about the likelihood of getting exposed to COVID. So there's the combination of genetics plus exposure. And I do firmly believe that public confidence in these vaccines will be to some extent related to, are people like me enrolled in the trials? And by people like me, I mean people in my age group, which makes a lot of immunological sense actually, but also people in my race and ethnicity group. So public confidence, I think, is related to that. I could tell you that in part because of our pushback from ACIP to Moderna and Pfizer, we pushed back very strongly many months ago about enrolling racial and ethnic minorities in the trials. One of the trials, maybe both, were actually halted, or enrollment was sort of suspended very briefly so that they could really reorganize and try to enroll far more minority individuals into these vaccine trials. And UCLA, for people who don't know, UCLA is involved with a couple of these trials, very involved, and working very hard to get minority populations enrolled in these trials. And particularly within Los Angeles, which is the most diverse community in the United States, I think this is super important.
Great. From Rochelle Dicker, how can we access communication training?
Yeah, communication training, this has taken years of effort for our group and multiple other groups. And I think what we may end up having to do with COVID is adopt some training methods and phrases and from some other groups, modify it based on the experiments that we may be doing, using these behavioral economic principles. And we're going to be randomizing people from the online panels into getting different kinds of messages. And then it may be possible to create rapid online modules. The study that I talked about with the HPV vaccine, we actually were using online modules to train. We didn't have to go into practices. Individuals, physicians, clinicians were able to review modules. So I don't exactly know how this is going to roll out. I know everything's on a very fast kind of warp speed type of speed, but there may be ways to either deliver phrases for clinicians to use or potentially even develop rapid communication methods. And CDC is actually looking into these right now.
That sounds great. I'll just keep going. I know we only have until 1:15, but I'll keep asking questions because there's a lot more. From Aladoni Adeyiga, regarding whether or not healthcare workers are prioritized for vaccination, is there data on rates of nosocomial or healthcare worker-associated transmission?
On race of the transmit?
On rates, sorry, rates of nosocomial
Rates.
or healthcare worker-associated transmission.
I think there are data, and others in the audience might know better. I don't know what those rates are.
Okay.
Sorry.
Here we go. Somebody has got two questions, but we'll see if we can get through both. This is from Aditi Dasgupta. How can we identify community partners to help engage at a local level? And the second question is, as providers practicing in a clinical setting with trainees, how can we get the training and also ensure our trainees are informed on how to message around the vaccine?
Yeah, I mean, I think the best methods is to use local community partnerships that are already existing. Individuals in the community have developed trust in local, regional, various, neighborhood community organizations. So the Community Engagement Corps, for example, from at UCLA, that's led by Arlene Brown and Keith Norris, has great connections with local groups. There are a number of different organizations within UCLA who are very close to these local groups. I don't think it would be helpful to create sort of novel local groups because this has all to do with trust, right? With confidence and with trust. And in terms of the training, there's going to be materials, I think, coming out from CDC. Many of us will be feeding information to CDC about some of the messaging. And I don't exactly know how we're going to be able to roll out some of this training over the next several months, whether it's going to be modules or just other ways of communication. But I think there's going to be, we're going to kind of shift into a real implementation phase of this pandemic regarding vaccines. And I think we're going to be probably inundated with different kinds of suggestions for how to use different strategies, not just communication strategies, but other strategies. For example, if somebody already got the COVID vaccine, they're not hesitant, or if they were hesitant, somebody was able to talk with them about their hesitancy. They need to come back for the second vaccine because the earlier studies have suggested that you really need 2 vaccines to reach immunogenicity based on phase 2 trials. And the efficacy data from the phase 3 trials are on 2 vaccines. So we're going to be using registries and other denominator-based systems. We can use our electronic health record. We could potentially use the patient portal. There's many ways that we can use to not just message initial vaccine, but message individuals to get that follow-up vaccine. And I think that'll be particularly important because, as I said, the vaccine is reactogenic and many people may get side effects, minor, but irritating side effects from the vaccine, and we need them to come back for the second one.
Great. Okay, and maybe in the last minute, from Daniel Waxman, should data transparency be part of an adoption strategy? For example, we never got a good explanation for the transverse myelitis case or cases at AstraZeneca.
Right. I mean, there are confidential issues regarding giving details about an individual case in a vaccine trial. So I think data transparency and transparency in the safety and efficacy is super important. It's going to have to be to some extent in the aggregate and not for very, very rare, cases. But I do know that data transparency is really important because one of the issues that I think underlie the trust problem is the lack of transparency of the processes that have been occurring by some organizations in this country. So I do agree with you. Data transparency is going to be really, really important. And that includes data transparency for minor side effects, not just really major side effects. I do know, for example, that one of the trials, and I'm not going to say which, one of the trials was stopped because of a potential very serious case. We found out, or the trial found that when they broke the code, learned that that person was from the control group, the placebo group, not the. So those are the kind of things that happen with these vaccine trials. And what the general public may not know, vaccine trials are halted not infrequently for a short amount of time when there's a signal, so that they can investigate this. This is not unusual. What's unusual is the rapid development of these vaccines. And the fact that kind of the public is really super aware of this. In the past, it hasn't been the case out in the public, so people weren't quite as aware of it. But this sort of stopping for a short time and starting, that is not unusual at all for these vaccine trials.
Fantastic. Well, I don't know if we've got all of the questions. We've got most of the questions in. So please, if you have any more questions for Peter, please feel free to email him. And yeah, I just want to thank you for a fantastic talk. That was so much great information, so much to digest. And yeah, we're looking forward to hopefully having a safe and good rollout, and just amazing feedback from the chat as well. Everybody's saying thank you, and they really appreciate all the information. Thank you so much, Peter.
Thank you. Sorry about the problem in my throat, but
no problem at all. That was really fantastic. We really appreciate all your time, and it was just a fantastic talk. Thank you.
Great, thanks. Bye-bye, everybody.
Thank you, everybody. We'll see you next week, same time, Friday at noon. Okay, bye.
Bye-bye.